Hello, everyone, and welcome to another edition of Colorectal Cancer Canada's Tush Talks. Colorectal Cancer Canada is the nation's leading colorectal cancer patient group, and Tush Talks are our way of interviewing experts in colorectal cancer care and research for the information that you need, be you a patient, a caregiver, a family member, or a practitioner. My name is Carl Bindman, and I'm your host, and today we are very, very lucky to be joined by Dr. Rebecca Auer. Dr. Auer is the Executive Vice President of Research and Innovation at the Ottawa Hospital and the CEO and Scientific Director of the Ottawa Hospital Research Institute. Dr. Auer is an internationally recognized translational researcher in the field of perioperative cancer therapies, and she has authored over 100 peer-reviewed publications. Dr. Auer believes that research is care and is dedicated to ensuring all patients are provided an opportunity to participate in research. Needless to say, thank you so much for taking the time from your understandably very busy schedule to join us today and to share your extensive knowledge on the topic of today's Tush Talk, cancer immunotherapy. Dr. Auer, how are you doing today?
I'm great, and thank you for the invitation to join you today. I'm really excited.
Wonderful. Maybe just to get things started on the most basic of footing, what is immunotherapy?
Yeah, great question. So immunotherapy for cancer actually has, it's quite a broad umbrella of different types of therapy. And the idea is, unlike sort of what we think of as traditional therapies, chemotherapy, radiation, even surgery, where you're directly attacking the cancer with your modalities. In this case, what you're doing is you're triggering or stimulating or unleashing, if you will, the immune system, and then your immune system will attack the cancer. The most or the most further advanced, I would say, immunotherapies that are currently used and approved in clinical practice for solid tumors like colon cancer are what we call immune checkpoint inhibitors. So essentially what we understand in cancers is that within the tumor environment itself, the tumor cells do look different than your regular cells. And so in theory, your immune system, if they could recognize that those cancer cells are different, then they would attack them, much like they would a bacterially infected cell or a virally infected cell. And so what these immune checkpoint blockers do is they take off this sort of signals that the tumor is giving the immune system to kind of not attack. And those are called checkpoints. So the immune cells get in there. In theory, they should attack, but the tumor says, just relax, don't worry, slow down, don't attack. And they become a bit exhausted within the tumor environment, these immune cells. And if you can turn off this checkpoint, then the immune cells can go and attack the tumor. And that's really what most people think of when they think of immunotherapy, although there are many other types of immunotherapy.
Right. And like you said, that kind is the type that is most used in colorectal cancers.
Yeah, and particularly in those subtype of colorectal cancer that I'm sure we'll talk about, which is called MSI-H or the MMRD.
Yeah, but I do think we will get to that in a bit, but just for more sort of groundwork, like, is immunotherapy more effective than like more traditional therapies like radiotherapy, chemotherapy, surgery?
Yeah, I mean, it's a good question. So in certain cases, it can be. And so again, what we know is when you can effectively get the immune system to eradicate the cancer, then you have all the benefits of having an immune system attack or defense against the cancer. And that includes becoming almost immune to that cancer. So what we do see is when patients have an amazing response to immunotherapy, that they tend to be cured. So the outcomes are really transformational for those patients that have a good response. But it doesn't work for everyone. It doesn't work all the time. And so we're really into this research place right now where we're trying to understand, so what are the cancers for which immunotherapy works the best? And when it doesn't work, why is it not working? And when it starts to work but then stops working, what are the secondary things that are happening that are preventing it from working?
Yeah.
And the one thing we do know about immunotherapy, particularly these checkpoint blockers, is that the more foreign your cancer looks to your immune system, the more likely it is to be attacked by your immune system, right? Because essentially your immune system was designed to attack not your own cells, but bacteria and virally infected cells. So these cancer cells need to look very different. And so how do cancer cells, which derive from your own cells, look different? It's because they accumulate all these mutations, all these defects in the DNA, and that makes them express abnormal proteins. And some of those abnormal proteins can look a bit like abnormal proteins in a bacteria or in a virus. And we call those abnormal proteins that the cell expresses antigens. And when the immune cells see those different proteins, they are more likely to react. So we know that cancers that have a lot of mutations in them, like those that are caused by sun damage, like melanoma, or smoking, like lung cancer, or bladder cancer, which is also associated with smoking and the toxins. We know those are the cancers that seem to respond better to immunotherapy because they have more mutations, so they look more abnormal to your immune system.
Right. And so that means that like your immune system will start to interact with them, but then like you said, there are these checkpoints, and so then they'll kind of slow down, and then the immunotherapy is about getting them not to.
Yeah, it's about sort of taking that break that the tumor is putting on the immune cells, taking the break off, and then the immune cells can then attack the cancer. But if the cancer doesn't look foreign enough, you can take the brakes off the immune cells, but they aren't so primed to attack, if you know.
Yeah,
what I
they'll
mean,
just kind of mill about in a crowd and be confused.
And they may just say, well, that's a normal cell because it looks similar enough to a normal human cell that you already have. So they say, well, it's not foreign enough, so we won't attack it.
Yeah.
And so that's why at the present time, checkpoint blockade works best. That type of immunotherapy works best for cancers that have a lot of mutations and a lot of abnormal proteins in them.
In colorectal cancers, we had talked about MSI-H cancers. Are those a kind of colorectal cancer that responds better to immunotherapy?
Absolutely. So what we mean when we say MSI high, it's actually called microsatellite instability. And that's kind of an old term from an old test that we used to do. So most people will use the term mismatch repair deficiency. Although I have to say in the clinic, we kind of use them both. But if you think about what that means, mismatch repair deficiency, what it means is that, when a cell divides, you have to duplicate the DNA, right? You have to take cell number one and you have to make all those chromosomes again. If you think back to your, high school biology, to make two
mitosis and
cells.
meiosis.
Yeah, exactly. So this is during mitosis, you have to duplicate the DNA. And what happens for tumors that have mismatch repair deficiency is that there's a mismatch between the two strands of DNA when you're replicating it. And so normally when that happens, we have all these different enzymes that come in and fix the DNA, say, oh, there's a mistake here. Before you're allowed to separate into two, we've got to fix this mistake. When you have a defect in this mismatch repair, so the DNA is mismatched, then the cell just goes ahead and duplicates with a mistake. And you can imagine if that happens again and again and again and again, you accumulate so many mistakes. And so these tumors have way more mutations, therefore way more abnormal proteins, therefore way more antigens than the average sort of a cancer. And that is the reason we think that the checkpoint blockade works so well for those types of cancer, because again, they look very abnormal to the immune system, but the immune system is kind of silenced or quieted by the tumor. If you can take the brakes off the immune system, it can go and do its job and attack it. And it's been quite transformational for those patients, for that type of colon cancer.
Mm-hmm. I think we'll circle back to talk a bit more about the sort of the science there, but on the practical level, like what are the differences for the patient of receiving immunotherapy versus other kinds of cancer therapies?
You mean in terms of the patient experience and
Yeah.
Yeah. So for immunotherapy compared to chemotherapy, it's definitely a very different experience. So patients, who have chemotherapy, I think many people are aware of the side effects, with hair loss in some patients and nausea and fatigue. And, there are certainly side effects, sometimes numbness and tingling in the fingers and the toes. And that's because chemotherapy is designed to kill the cancer, but it also kills other cells in the body, like your bone marrow cells and your hair follicle cells and that kind of thing, which is why you have those side effects. What immunotherapy again does is it turns the brakes off the immune system. So many patients will have like an immune response, sort of as if they have a fever or a flu, as their immune system gets all jacked up and starts to attack, which lasts for a very short, limited period of time. Other patients can have really very few, if any, symptoms. And then still others can have, and sometimes they can be quite serious, but an autoimmune reaction. So essentially their immune system gets jacked up and then starts to attack the normal tissue as well as the cancer. And that can be anything from, thyroid problem to, an attack in the gut, which would give you something like colitis, or you can get, attacking even in the spinal cord and brain. And so there are some, they're less common, but there can be some very serious side effects to immune therapy.
Right. And I guess something that strikes me right now is like, if I'm a cancer patient and I'm getting immunotherapy, does it feel like I have a fever for the entire course of the treatment?
Good question. No, I think when you do have, some patients will get a fever after the treatment, but it's often only for like a few hours.
Oh, okay.
Afterwards. And the treatments tend to be, depending on the regimen, every 3 to 4 weeks. So it's
And what do they
quite,
look like? What is the sort of practical, you go in for immunotherapy treatment and what happens to you?
It's an intravenous infusion. Some patients will get immunotherapy with chemotherapy, although in colorectal cancer, it's usually, if you're getting immunotherapy, you're just getting immunotherapy. You go in, you get your infusion, and then again, I can't speak to all patients. Some patients will say, well, I feel great. I have no side effects at all. Other patients will experience kind of like fever and chills, sometimes some nausea or even a change in the taste of their mouth. So it's definitely, there's a spectrum of side effects, but I think by and large, patients would say it's better tolerated than chemotherapy overall.
That's good. That's good to hear. We actually have some questions that we've fielded from colorectal cancer patients that we've worked with, and when we have support groups and one-on-one support, which just to the public, you can access that. You visit our website or contact support@colorectalcancercanada.com. And people have asked, like, how do you get access to immunotherapy? How do you know that you are a candidate to get immunotherapy?
So currently for colorectal cancer, the only approved indication would be patients who have MSI high or MMR deficient. We just talked about colon cancer that's already metastasized, so already spread outside of the colon. That's currently the approved indication. And I believe that that is approved in funded in every province in Canada as a single agent. So it's a single checkpoint blockade. So every patient should have as a reflexively done when they have a biopsy of their tumor, they will report whether or not it is what we call MSI high, or you have this sort of DNA mismatch repair deficiency. And then based on that, your doctor would determine if you're a candidate for immunotherapy. There are some sort of emerging data, I would say, coming out around using immunotherapy. So for example, there was a really exciting study that came out of Sloan Kettering of patients with rectal cancer. Instead of getting sort of chemotherapy and radiation followed by surgery, these patients with MSI high got single agent immunotherapy, and 30 out of 30 patients, 100% of patients had kind of a complete response and never needed any additional treatment. So very exciting, but a very small study. And that's now, there's a clinical trial that's ongoing across North America to try and ensure those results are indeed true in a larger population. And that would probably be one of the next places where immunotherapy in this, again, MMR deficient colon cancer, rectal cancer would be. And then the other study that recently came out looked at combining 2 different immune checkpoint inhibitors, the one that we currently use that's approved for metastatic colon cancer, and then a second one. And that seemed to do better for sure than chemo. Whether it's better than single agent, I think the jury's still out. But that's, again, another kind of emerging frontier. But these are all in that subgroup of about 20% of patients, 15 to 20% of patients who have this mismatch repair deficiency.
Right. And when you say single agent, just for clarity, that is if you're getting that as the only treatment.
That's right. So it's the
Okay.
only thing you would be getting. For
Oh,
patients who do not have mismatch repair deficiency, there currently is no strong evidence that immunotherapy, particularly on its own, but even with chemotherapy, is going to work. And so many smart minds are working on figuring out why this is. And I have no doubt that we will figure this out. We will figure this out one subtype at a time, one patient at a time if we have to. But there will be a time when we have different strategies for those patients for sure.
that's great. I do want to ask a bit more about that research in a second, but I have a couple other questions from patients that I think are interesting and other people might appreciate hearing as well. Does immunotherapy, if you are MSI high and you get immunotherapy, does it have an impact on like cancer recurrence more or less than sort of other more traditional therapies?
Yeah, it probably does. So like I said, when you're treated with immunotherapy, it seems like the treatment is quite durable in a sense that if you have what we call a complete response, so it looks like the tumor's basically gone, there seems to be very low risk of the tumor coming back. Now, keeping in mind that, we only have sort of a, I don't know, 15, 20-year experience with these drugs. So we're still a bit early in the trajectory of understanding them, but it does seem like that the patients will be treated and they can be cured. And that's something that for metastatic colorectal cancer in the absence of surgery has not really been seen very often, that, chemotherapy alone or chemotherapy plus radiation could cure patients. So that's a pretty exciting part of it. And again, it might be because you have this immune response to your cancer. It's sort of like being almost vaccinated, if you will, against your cancer. You've become immune to it, and that specific cancer can't come back.
Right. And with the notable difference from a vaccine, of course, being that you would need to get the cancer first.
That's right.
Yeah. For my own edification, like the newness of immunotherapy seems really like something special in sort of the field of cancer treatment, right? Like how long has chemotherapy been the standard treatment for most cancers?
Yeah. Chemotherapy probably has been around, maybe since the 1930s, 1940s, when we started to, look at using, essentially it came from chemical warfare, right? Using poisons to kill enemies. And then wait a second, we can dial down the dose of the poison and we can kill the enemy, within, which is your cancer. And so that field really it evolved from that and has been a mainstay. And I think our mainstays for cancer treatment, surgery, chemotherapy, and radiation have really been around for quite a long time. The reason why, partly the reason why immunotherapy was so exciting is because it's a completely different way of looking at the cancer. And because you're not targeting necessarily the cancer itself, you're targeting the patient's immune system to fight the cancer. So that's part of it. It also had some really incredible, I guess, miraculous, outcomes. Patients who, were kind of told like there is no cure, but you can try this immunotherapy on a clinical trial, and then they are alive and well still 5 and up to 10 years later. That's pretty exciting. I think the one issue is that unfortunately it doesn't work for everyone. It doesn't work for all cancers. And even in the cancers that it does work for, it doesn't work for every patient, right? And every tumor. And so we really need to continue to focus our energy on understanding why that is, so we can, add additional therapies together to try and make it work for more patients.
Yeah. One of the special things I think about having you on as a guest is that when you say we, you literally mean we. You're the CEO of one of the major research groups that is doing this work. So I thought I might ask you, since we have you, like talking about research into MMR and research into MSI-H and non-MSI-H cancers, what are the things that are sort of in the pipeline that you and your community are working on, if that's something that you can share?
So in the immunotherapy, there's some absolutely exciting therapies coming down the pipeline. Exactly where they are in the pipeline for colorectal, I'm not necessarily going to be able to comment on, but so personalized cell-based immunotherapies are so exciting, and they haven't really found a place yet for solid cancers, but in what we call liquid cancers, so things like leukemia, they have had the same kind of transformational outcomes. And so cell-based immunotherapies are usually when you would take immune cells out of a patient's body, you would manipulate them on the outside in the lab to make them super killers against the cancer, and then you would put them back in. And so we can do that by taking immune cells out of the tumor, and that's called tumor infiltrating lymphocyte therapy. And that's had some incredible results in melanoma and just starting to understand it in other cancers. And like I said, in leukemias, we've had some incredible results with these things called CAR T cells. CAR stands for chimeric antigen receptor, but all that to say is you engineer the T cells against a very specific protein on the cancer, and they go in and attack. So again, there's some barriers to treating cancers like colon cancer with these therapies, but I think, with time, we'll be able to figure out how to overcome some of those barriers.
Sorry, go ahead.
Sorry, I was just going to say the only other really exciting one that I think has really transformed some early studies, particularly in cancers like pancreatic cancer, which has, as you know, a pretty dire outcome, pretty bad prognosis, is vaccine-based therapy. So understanding what are the actual proteins within that cancer that are foreign, and trying to then give the patients like a vaccine to stimulate their immune system. And when you use that in combination with other immunotherapies like checkpoint blockade, they've seen some exciting results as well. So more to come on that for sure.
Phenomenal. And that's all sort of research and treatments that would be beneficial to colorectal cancer patients who are not MSI-H.
That's exactly it.
Yeah, which is the majority. Well, that is more or less the list of questions that I had for you, but I wanted to ask you if there is anything that you would have wanted me to ask, or anything you think is really important for the colorectal cancer community in Canada to know about these treatments.
I think for me, it's important to mention that, I finished my training about 16 years ago at Memorial Sloan Kettering. And when I left, there was kind of one new drug on the horizon. It was called Avastin or bevacizumab, very exciting, and it targeted the vasculature of colon cancer. But other than that, it had been sort of just chemotherapy, radiation, combining them in different ways. And that was kind of where the field was at. And in the last decade and a half, it is like an explosion of biomedical research has hit the forefronts of therapy. And when I graduated or when I left Sloan Kettering 15 years ago, and if I would have seen a patient with MSI-High colon cancer with metastases, I would have said, I'm sorry, but your cancer is not curable. And of course, who would have known that 15 years later the chance of cure would be as high as it is with that particular subtype. So I never say that to patients anymore. I always say it's not curable yet. Because even in my own career and even in patients' own cancer journey, there are therapies that are being discovered more and more quickly. So I guess there's just a lot of hope in research. I'd like to make sure people know that. And clinical trials also, they may not have all the answers, but they certainly help to understand the disease better. And you never know what's around the corner.
Wonderful. Well, thank you for that thought and for all of your insight and expertise. For people who want to follow along with your work, where can people find you or see your work, I guess, outside of prestigious medical journals?
Well, we do have a website for our basic science lab research, which is really focused on therapies around the time of surgery for cancer patients at auerlab.ca, auerlab.ca.
Wonderful. Well, for folks who want to learn more, you can head there. And of course, for some other insight from Dr. Auer, you can visit our YouTube page where Dr. Auer we have been lucky enough to have Dr. Auer talk at some of our conferences and provide presentations. So our YouTube page has some of those as well. And like I mentioned before, you can visit colorectalcancercanada.com or email us at support@colorectalcancercanada.com or info@colorectalcancercanada.com to reach out with any questions that you might have about MSI-H, immunotherapy, colorectal cancer generally, whatever, we're here to help. And our social media it's on the screen. But Dr. Auer, thank you again so much for joining us. I've been Carl Bindman. Have a great day.